You're live, Doc. Hello? Doc? You're live, Doc.
For that issue. But then it raises some other questions too. For example, well, what is a low carb diet? How did they define it in here? And I think you'll see that they defined it fairly loosely. And once you start getting into that, what's a diet? Is it a change in lifestyle, permanent change, or is it a 6-month thing? That comes up in this article as well. Another thing that comes up is very low carb diet, because one of the things they found was the quote, very low carb diet didn't seem to work as well. Now, what does that mean? And why would a low carb diet, but not a very low carb diet, work? Was the very low carb keto? And is this saying that keto doesn't work? A lot of questions on this article, and I'm very excited to cover it today. I think it again deals with some very critical indicators, some drivers of our health that people are just either they're ignoring or they're confused about. We're going to go through a few things. Before we do that, as usual, we'll cover a few things in terms of other content that we offer. As usual, since COVID-19 is one of our major determinants of health right now, especially for our population, the baby boomers, the folks that are starting to get insulin resistant, and therefore starting to become at risk for heart attack and stroke. And guess what? COVID-19 cytokine storm. So we can't be focused on baby boomer health and not cover some COVID stuff. So we've got a lot of stuff on that. But we get into things like we're talking about today as well. Diet. You know, the USDA just made a big failure on the USDA guidelines yet again. And why did they do that? Was it because they were too friendly with their the folks that were the industry that was funding them? Big food, big pharma. Okay, so before we do get into the program, again, a couple of other comments. As before, each New Year's a big time for us in terms of actual patient care, because people say, New Year's resolution, I'm going to finally get my health in order. And more than anything else, that ends up involving, I'm going to change the way I eat. That's a big deal, both in terms of managing your health, in terms of New Year's, and we always try to help people out. Calcium score. Now, James, you said that you joined us. You came sliding in home right at the last minute. You and I were talking about the show before it came on. Did you want to make a comment about calcium score?
Well, good morning, Dr. Brewer. Good show. Yes, you know, the calcium score, the reason that you offer this help for those who are listening that may have had a calcium score, or in those that have not and don't really understand the funnel of cells that happens in healthcare, as listeners may know, you and I have run healthcare systems before. The calcium score is a legitimate test, and it tells you, of course, whether you're, the condition of your arteries. But it often, not always, but often is the top of a funnel of cell cycle that the healthcare system is getting you in. It can disturb you with a calcium score and suggest the follow-up might be a stress test. You can speak to how often stress tests are actually false positives. It's a significant amount of time. So because of that, we need to probe a little bit deeper and do an angioplasty. And then, of course, with an angioplasty, it's an expensive and somewhat risky a procedure to go through. And then based on what they find there, you may have a stent put in. When in fact, maybe there was a lifestyle change that calcium score should trigger a disturbing event in your life to make some changes. But would you not say, Dr. Brewer, that instead of getting on that financial cycle that funds the world of cardiology, always put your phones on silent before you start a YouTube show.
That's a good idea.
Instead of funding that system, you might find a lifestyle change as may accomplish everything that you need. And so that's the reason we're emphasizing, if you have a positive calcium score and you're disturbed, good, you should be disturbed, not good that you had it is what it was. But there is an alternative that is proven in studies as a healthy alternative to address most conditions once you have a positive calcium score. And you can tell more about how we treat that, what we do for individuals to, once they've identified that they may be at risk.
So you bring up several good points. I don't have the statistics and I can't say for sure, but it's just an impression. I think more patients come to see us because they've had a positive calcium score than anything else. Another one yesterday, and this individual was a gentleman, 75 years old, and he had a positive calcium score. As you began to dig deeper, he was like so many of our patients, over half. He had weighed 20, 30 pounds more just about 3 or 4 years ago, back in his early 70s. At this point in time, he had significant calcium, but and obviously some old plaque, but it was all stable, which you're not going to see on a calcium score. A lot of people have compared my channel to Ivor Cummins until the COVID thing came up, and then Ivor and I took 2 different directions. He became more of the he went a different direction, but I think both of us would agree that calcium score is a very appropriate test. I tended to use a lot more CIMT, but simply because I had a couple of good sources. I've really only found 3 good sources for a reliable CIMT in the country. The reason I used CIMT is that it was able to tell me, like in this gentleman yesterday, he didn't have any soft plaque. Now, here's the big issue, and you may have thought I was about to ignore it. The big issue is going down the rest of that wrong path. If you look at what most people do, where most cardiologists take people, it's okay, you got a positive calcium score. Most cardiologists are still not using calcium score, but when they do, let's do a stress test. And guess what? Just Google it. 1.5 million out of the 8 million stress tests that were done prior to COVID per year. We knew, the NIH said, we knew it was going to be either a false positive or false negative. Well, guess what? Whether it's a false, even if it's a false positive, and we knew that about 25% of them would be false positive, you're still going into the cath lab. And guess what? If you've had those 2 things, what's the probability of seeing plaque? And guess what? If you're a hammer, everything looks like a nail. If you see plaque in there, you make an assumption that I'm going to put a stent in there and the stent's going to stop that, prevent a heart attack. Now, 10% of stents do something good. They're actually treating a heart attack. The other 90% of stents are put there to, quote, prevent a heart attack. And if you look at the studies that have been done over the past 3 to 5 years, it's really clear. Stents don't prevent a heart attack. Over the past year or so, it's also become clear with the ischemia trial that even bypasses don't prevent heart attack. So you get into a situation similar to what I'm sure happened with Tim Russert. He goes in, he gets a stress test. Now he was on the other side. He had a, quote, negative stress test. So he goes home thinking, you know what? I know I've gained a little bit of weight. I'm up over 40 inches on my waistline now, but my stress test says I'm okay. So I'm good. I can breathe a sigh of relief and continue those business breakfasts, those business lunches, continue to pack it on, but I'm running, so I'm good, and my stress test is okay, so I'm good. And we all know what happened to Tim. And if you don't know what happened, 3 months later, he had a heart attack and died at his place of work. So stress tests are not a great way to go. They just take you down that path. Anything else before I move on, James?
No, that's great. In our newsletter, for those who are signed up for our newsletter, you will see that we mentioned this week how to do a brachial test. So you talked about CIMTs, or carotid intimal medial thickness test, but you also in this month's newsletter discuss how you can take a blood pressure cuff. So if you want to pitch that a little bit, it's very similar to look and see what may be occurring using something you may already have at home to run an ad hoc test.
It is. I have to tell you, James, in some ways, I've had mixed emotions about putting that video up there, because one of the things that's done, it's been a very popular video for us. Do-it-yourself plaque detection using ABI, ankle brachial index, looking at the blood pressure in your arm versus your ankle, with the assumption that plaque at a significant level is going to change the ratio there. Here's the problem, and I don't think I was strong enough on talking about the problem with that. A, it doesn't rule out plaque. B, you can have plaque which doesn't impact this at all, and still it'd be enough plaque that cause a heart attack or stroke. And so it was really more of a question, is this a do-it-yourself plaque detection? And again, I don't think I made that case well enough. I think that's one of the things we need to keep our eye on in terms of our own content, to get back and make that case stronger, that a negative, you can't use it to rule out plaque. You just cannot.
Well, let me ask you something. Well, I know we're down a bunny hole, pardon me.
Well, I'll tell you this, even though I apologize for going down bunny holes a lot, a whole lot of folks then come back and say, the bunny holes are the best part. So fire away.
Absolutely. Well, Steve Mitchum in the questions asked, and this is a good time to answer it while we're on the subject, is a CAT scan with contrast as good as a CIMT?
So actually, if you go, I don't know if Gilbert is still showing my screen. There's a reason I went to my screen. Prevention Myths. It's the book, the upcoming book that I keep promising, and my co-author, the three of us, my co-author and my publisher and I, can't seem to get our act together. This past week, there were problems with one of them being in Mexico with being ill, and the other one waiting on each other. Anyhow, bottom line is that this book, if you have an interest in the topics that we've just covered, this book goes into detail. It starts off with that Tim Russert story, but it goes way deep into plaque. Plaque is what's, it's causing the problem. Now, there are several different ways, and it's like James started out. Your typical progression is Framingham. From Framingham, if you've got risk, go to statins and to the stress test. Well, the Framingham is based on old data, and it results in way too many people going on statins. Stress test, we've already talked about, major problem. Getting a needle stuck into your groin and a tube catheter up to your heart, that's not fun, and that's got its own set of problems. And then that leads almost inevitably to a stent, which doesn't prevent a heart attack. So that's what this book talks about. It goes into the details on how these things were developed. But more importantly, and back to your question on this bunny hole, what are the ways of evaluating plaque, and how should we do it? And we talk in depth about 3 ways. One of them is the CIMT, which we just discussed for a minute. The second one is calcium score, which you just brought up. And the third is what the question that just came up, CT angiogram. A CT angiogram is, it is the up and comer. Even a lot of the guys in the standard medical community have already begun to embrace CT angiogram. One of the key things that the CT angiogram does, if you go back and you look at the COURAGE studies and a couple of the studies that compared this, what they did was they said, look, we're going to have the cardiologist do whatever he or she would normally do. That's usually going to be a Framingham stress test, all that other stuff. But in the study arm, we're going to have them add a CT angiogram. Scott Hart study was the other one, the two big ones, Courage Trial and Scott Hart, I think. Here's what they found, that there were actually a few more procedures early on in the study group, the CT angiogram group. Overall, the procedures done were the same. So it wasn't the procedures. But here's what did happen, and here's why you saw more procedures early on. The CT angiogram is better than any of these other technologies at showing you where you've got plaque. We had a fellow that worked with us for about a year or two, about a year. His name is Jerry Kurth, and he said, Ford, you got to look at my CT angiogram. He said, I mean, it was ugly, but that was perfect. Here's what I did with it. I took the image and I taped it to my refrigerator door. So what that does, I mean, as you see, James, it continues to go back to this theme. Small amounts of plaque can cause this problem. The typical ways of looking at it, Framingham, stress test, angiogram, really are not working. The simpler ways are working, but they're still not leading to procedures so much as they're leading to recognition that I have plaque and changing the lifestyle. Right. So that's where I've given you a 3 to 5 minute summary of the book.
Well, just remember the old saying, things that may not prevent a heart attack do pay for Cadillacs.
And any other comments before we move to on to the next phase? We're going to try to skip through some of these just to make you aware. Though we're continuing to get content out on our on our website. It's continuing to work. It's continuing to become a destination website where people actually go and learn.
Right.
And
I would emphasize right now, again, another good time is we're giving away the CVI course. So you can sign up and take the CVI course for free, which will cover a lot of this. So I recommend everyone that's listening, go take the CVI course for free, learn the baseline of what we're doing at PrevMed, what Ford's model is, and it's reversing. It's reversing disease, reversing chronic disease. You can reverse this stuff. You make a 180-degree turn in your life. Most people can make tremendous improvements, and that's a great course to start with, and it's free. You're making it available free.
Good point. I pulled up the courses while you were talking. There's a reason why these are the courses that we have. They're the core curriculum. You don't need to know a whole lot more than the plaque evaluation course, the insulin resistance course in terms of what's the root cause, and cardiovascular inflammation. You know, am I in danger now? Or if you want to get all three of them and get more of a comprehensive course, we have the conference proceedings, all of which are available. So let me move on. And if you're one of those guys that prefers to hear on podcasts, we've got plenty of information on the podcast as well. But let's get a water ball, Gilbert, and then we'll go into a transition. Actually, I messed up. I did have one more slide. It's our totally unrelated science issue slide, a quick one slide bunny hole. I gotta make a comment about it. And here's my take on it. I have volunteered to become I'm a physician. I trained in prevention. I taught prevention. I know how to give. Actually, when I was at Kroger in the little clinics, I ended up testifying to the FDA on a methods of mass vaccination. I volunteered here at Lexington Fayette several times to help them give vaccines. Haven't heard back. I volunteered for over at Louisville, Kentucky, about an hour away. What I got, I ended up, one of the calls I made was to the state COVID line. And they said, yeah, we really need help. We really need help. But here's the number to call. Got nowhere. So here's my perspective. State and local governments and local hospitals tend to have huge bureaucracies, and they approach things bureaucratically. Unfortunately, bureaucracies are not built for efficiency. Tens of millions of lives are currently depending on their ability to efficiently get that vaccine out there. And there was an article I read recently about Southern California. Their vaccine lines aren't moving either. There are many barriers. There's no part-time shift available. So the only available shift is 10.5 hours for a doctor to volunteer or a healthcare person. It's really going to be more nurses than anybody else. There's a lot more nurses available to do this than there are docs, but they only take 10.5 hour shifts. So they get plenty of volunteers on Saturday, but not on Monday through Friday. There's just a huge number of bureaucratic processes that's jamming this thing up. In LA, the health website requires 7 to 10 clicks before clinicians can sign up. I found the same thing here in Lexington, Fayette. I had to look and look and look, and I went to multiple websites. I finally found a tiny little statement at the bottom of one of the back pages. Are you a healthcare person? You want to volunteer to give vaccines? I did. I clicked on it. I filled all that out. Over a week ago, haven't heard from anybody. The frustration isn't only in LA. 2 former San Diego County Medical Association presidents have been trying to volunteer as well, but they've been thwarted by a confusing array of steps and processes, too many forms, county officials failing to take them up on their offer. In some, just like Lexington Fayette failed to take me up on my offer. In some locations, doctors are to go through training and a quiz to verify they know how to give a vaccine injection. This is keeping the vaccine from getting into arms. So James, unless you have any other comments about that space, I'm going to move on to the program for today about low carb.
One quick comment, and that is how good last week I was watching. I was ill, and I appreciate the good doctor got me back healthy after last week's event. But last week's vaccine show with Dr. Vigorous was extraordinarily good. So anyone that hasn't seen that show, it's archived. They should go back and watch it. You and Dr. Vigorous had fantastic chemistry together, great knowledge. It was my favorite show. Maybe that should tell me something about being on here. Get on there more. But it was a great show. We covered a lot about vaccines on that show and a lot about the virus. So I highly recommend, if you're interested in this subject, go back, find that show, and watch it with Dr. Vigorous and Dr. Brewer. I highly recommend it.
It's a good point. Thank you very much, James, and thanks for your humility as well. Glad to have you back. Glad you're feeling better. One of the things that we didn't cover, and I just sent one of the articles to Chris to talk about the projections for the mutant, one of the mutant variations, one of the new variations to be dominating in the U.S. And right now, the CDC's projecting that that'll be by March. And I think they're referring to the UK variant, which now has a new name, sort of like the artist that was formerly known as Prince. It's the variant that was formerly known as the UK variant. So anything else before we get to the content for today, the program? Okay, type 2 diabetes reversed with low-carb diet. Whenever you see stuff like this, it's helpful to start saying, okay, well, how do they define each of these things? How do they define type 2 diabetes? How did they define reversed? And then how did they define low carb? And how did they define diet? So these are all questions to be thinking about as we go through the details. So people with type 2 diabetes have a low tolerance to carbohydrates. Well, you would think, but again, you get into some of the folks that are just uber plant-based, they say it's really all fat that causes the problem. I don't agree with that, but we'll get to that a little bit later. That's one of our discussion points. Eating excess carbs increases blood sugar levels. It eventually requires people to take insulin or diabetes medication. According to Mark Cucuzella, a professor at the West Virginia University School of Medicine, has published several studies on dietary changes in diabetes. Their bodies do not metabolize and respond well to carbohydrates. Well, that's the truth. And the end result is high insulin levels and hyperglycemia, or high blood sugar levels. Yes, that's true as well. And either of those things, high insulin levels or high glucose levels, can cause inflammation, which in turn causes the inflammation of the causes a burn of the lining of the artery wall. That burn of the lining of the artery wall causes cholesterol, at whatever level your cholesterol happens to be, to seep through that lining. It won't go through the next layer, the media or muscle layer. So it gets stuck. It gets stuck between the intima layer, the lining, and the muscle layer, the media layer. That's why we look at CIMT, the carotid intima media thickness test. You're measuring the amount of plaque in those two layers. However, restricting carb intake to manage type 2 diabetes is a controversial topic, believe it or not, largely because trial results have so far been pretty inconclusive. Now, that's an interesting question, which we can discuss again later if there's an appetite to do so. So here's a couple of the articles. One is BMJ, again, one of the major medical journals in the world. You can criticize it just like you can criticize any of them. But here are the two topics: efficacy and safety of low and very low carbohydrate diets for type 2 diabetes remission. Systematic review, meta-analysis. Now, one thing I'll stop and say, remember, meta-analysis is not just one clinical trial. It's a study of all the other clinical trials and studies that have been done and published. Meta-analysis of published and unpublished randomized clinical trials. The other one is nutrition therapy for adults with diabetes or prediabetes, a consensus report from diabetes journals. To better understand the impact of a low-carb diet, researchers that published in this BMJ article analyzed the data from 23 trials that involved 1,357 patients with type 2 diabetes. The new meta-analysis was published in BMJ. Researchers found that type 2 diabetics who followed a low-carb diet for at least 6 months experienced greater risks of remission than those who did not. I'm going to stop and make an editorial comment. If you read, Jenny Ruhl, R-U-H-L, runs an award-winning site for diabetics. It's called Blood Sugar 101. She wrote a book called Blood Sugar 101. You can learn an immense amount just reading the first 60 pages, depending on how quickly you read. Spend about an hour with that book. You learn a lot about prediabetes. She wrote another book. It was called Diet 101. And in that book, she had a couple of key things to say. One of them is eat to the glucometer. And if you're eating to the glucometer, which James has become a passionate supporter of, if you're eating to the glucometer, you're not going to have many arguments about eating a low-carb versus high-carb diet. The other thing that she brings up, which is a critical point in Diet 101, is it's not a diet. It's not 6 months. And that's the problem with randomized clinical trials. With a randomized clinical trial, you've got to get someone who's agreeing to eat a certain way, and they're only going to do it for a certain time period. It has to be a permanent change in a lifestyle, the way you eat. So it's almost, if you begin to understand that it's not a diet, it's a changed lifestyle, you begin to understand the problems in saying we're going to do a randomized clinical trial for diet. Who's going to stay there for even 6 months? That's the problem when you start looking at randomized clinical trials. So the BMJ findings are consistent with the ADA's 2019 recommendation on carbs. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia, and may be applied in a variety of eating patterns that meet individual needs and preferences. Now, that may sound like a little bit of weasel wording to you. It does to me, especially there at the end, and may be applied. But that's actually a huge improvement over where they were 2018 and before. At 2018 and before, ADA folks were saying, carb it up. Yeah, a whole different set of battles, which I'm not going to get into because, we've only got like an hour or so. Previously, the ADA warned against diets under 130 grams of carbs a day because people would be deprived of, quote, essential nutrients, end quote. So, not going to make more comments in that space. So, researchers first, so let's go back to this BMJ study. Low carb diet, how did they define it? I've asked that question a couple of times. They defined it as 26% of daily calories coming from carbs. Well, James, maybe you can be doing some of the math on a 16 to 1700 calorie diet. And, how many carbs would you have to do? How many grams of carbs? So I'm going to give you a few minutes to do that while I finish this part of the presentation. And then they had the very low carb diet, 10% of daily calories coming from carbs. And is that really like more of a keto kind of diet? And again, I can't help, when I'm asking questions and trying to sift out fact versus misunderstanding, there's really no definition of carbs here. And it reminds me of the conversation that I had with David Mines, who is in this same space, cardiovascular prevention, and he was a public speaker for like over 20 years. And he was one of those as well. He talked about carbs, carb it up, the typical old style. Until about a couple of years ago, he and I were sitting in his car prior to a meeting. And he said, Ford, I have to tell you, it's so frustrating and embarrassing. I am a professional in dietetics. And for so many years, I've been telling people to eat carbs. So part of the confusion there was just about 6 months ago, he and I were, or 6 to 12 months prior to that conversation, he and I were in a debate at one of our meetings. I was on the low carb side. He was on the ADA side at that point. This was about 3 years ago. And I said something about decreasing carbs. And he said, are you telling me to decrease broccoli, to decrease cauliflower, to decrease asparagus? Because these are all high carb foods. They're made of nothing but carbs. So again, pardon me for the bunny hole, but we've got to be careful about what we're defining. No wonder we have so much argument as humans. We can't define things very well. So at the end of the day, I think we have to be more careful about saying low carb or glycemic. So participants were evaluated at 2 intervals at 6 and 12 months. The primary outcomes were type 2 diabetes remission. Well, speaking of definitions, what did that mean? For their study, it meant as a person who has previously been diagnosed with type 2 diabetes now has a hemoglobin A1C of less than 6.5%. Well, those of you who followed our channel know that there's a significant challenge in terms of comparing A1Cs between people. It's impacted by hemoglobin. Fasting glucose, less than 7 millimoles or 126 milligrams per deciliter, or with or without diabetes medication. So that's not the way I would define full-blown diet. Well, that's one of several ways. I wouldn't use the A1C. I would use the fasting glucose, but most often I use the peak glucose on an OGTT, oral glucose tolerance test. They also talked about weight loss, A1C, fasting glucose, and adverse events in terms of trying to define someone as, quote, in remission for type 2 diabetes. They also looked at secondary outcomes too, health-related quality of life, biochemical laboratory data. But as you see, they really, where's the stuff about heart attack and stroke, which is one of the key things that we want to look at. At 6 months, the low-carb diets achieved a 32% diabetes remission, which is higher than the other diets. Remission was defined, as we said, A1C less than 6.5, fasting glucose less than 7 or 126. Smaller, non-significant effect occurred without diabetes medication. Additional benefits for the low-carb diet include large improvements in weight loss, significant weight loss. And I can tell you from doing this for a living, there is nothing like losing body fat to improve this situation, pre-diabetes, diabetes, insulin resistance. You're usually going to get a significant decrease in triglycerides. And again, those are the three things that they're talking about: large improvements in weight loss, triglycerides, and insulin sensitivity. So they may have been using some slightly different definitions, but we're all focusing on the same issue. Researchers acknowledge weight loss is the primary driver of remission. I do too. Again, I do this all day, every day, and weight loss is king. However, while low-carb groups lost more weight compared to the control groups, around 7.4 kilograms. So what is that, 15 pounds or more, 20 pounds? The weight difference as well as remission disappeared by 12 months. Remember what we talked about? These are clinical trials. In other words, you're randomized to, okay, for 6 months, I'm going to agree to this diet. They're not committed to making a change on their lifestyle. The decrease in benefits may have occurred because patients stop sticking to the diet over time. Well, that's what we just said. More research, as most of these things do, they end up calling for more research to be done in exploring long-term adherence and effects. I will say this, in my own experience, I have a few folks who do very well on a ketogenic diet. More folks more often do better on a kinder, gentler, low-carb diet because it's just easier to stick to. This is not a sprint. Sprint lasts, 8 or 9 seconds. This is not even a marathon. Marathons last between 2 and 6 hours, depending on how fast or slow you are. This is month after month, decade, year after year, decade after decade. So this is a permanent change that we have to look for. Also, very low-carb diets were less effective than low-carb diets for weight loss. However, this may have been explained by diet adherence. People on the very low-carb diets had more difficulty adhering to the very low-carb diet. The idea of diabetes remission is somewhat a new idea. I wouldn't say quite new, somewhat new. We don't have enough evidence yet that remission is permanent, so a lot of research is needed. I will say this, it's really clear that it's not permanent. You don't, the weight loss will decrease. There are a couple of things that impact the receptor, the insulin receptor. One is your age. Another is your body fat. So if you lose body fat, you will improve your insulin resistance. I can't go further without mentioning one other little bunny hole. Once we get past age 65, we have to be very careful that it's not just losing weight, that it's losing body fat, because you're 65 and older is notorious for maintaining the same circumference, the same size of your leg, but muscle being replaced with fat. That is very dangerous, and that's one of the biggest causes of cardiovascular inflammation and insulin resistance. The amount of carbs people consumed on a low-carb diet varied, ranging from less than 26% to 45% of daily calories from carbs. That's not a low-carb diet to me, unless my math is wrong. That's a very, very gentle, very easy diet, unless it's including all of those broccoli, all of those fiber-related carbs. This could impact whether some low-carb diets work better than others. None of the studies control for protein intake. Many of the low-carb diets doubled the calories from protein, which could also have impacted the chance of remission. None of the studies controlled for medication use, making it difficult to really see the impact of low-carb diets alone. When beginning a low-carb diet, it's important to monitor blood sugar levels and to have the assistance of a doctor or registered dietitian who specializes in diabetes and nutrition. I would also say, when you talk to the dietitian, find out first if they're open and amenable to a low-carb diet. More and more are, especially over the past couple of years. Dietitians like David, many of them have made that transition. Even the ADA has made that transition. So you're not seeing it so much anymore, but you still see it. Dietitians who say, and doctors who say low carb is bad. So we're going to go and talk about, we're going to get a quick minute or two on this video, and then we'll go into Q&A.
Meet Jim. Jim's got type 2 diabetes and wants to put it into remission. Meet Jim. Jim's got type 2 diabetes and wants to put it into remission. What's remission? To explain, let's take a look inside his body. The pancreas is a really important organ that makes the hormone insulin. Insulin travels around the body and helps our cells to use glucose as fuel. But in people with type 2 diabetes like Jim, insulin stops working properly and there might not be enough of it at the right times. This means glucose builds up in Jim's blood, damaging his body. Jim used to manage his diabetes with diet, but now he needs medication to stop his blood sugar levels rising. But our scientists thought there could be another way. They wanted to see if type 2 diabetes could be put into remission. They believe a buildup of fat inside the liver and pancreas could be the root of the problem. They're running our direct trial, testing a new remission program, and Jim is a trial volunteer. With support from a dietitian, he swapped his usual food for low-calorie soups and shakes, which helps him to lose weight quickly. After a few months, the dietitian helps Jim to keep the weight off by eating the right amounts of healthy foods. Our scientists looked at what was happening inside Jim's body. Over time, the fat inside his liver and pancreas started to disappear. His pancreas is now making the right amount of insulin at the right time, and his insulin is starting to work properly. This means that Jim's blood sugar levels are healthy without needing any diabetes medications. He's in remission. Jim still has an annual review with his doctor, but he's now much healthier. Back out on his bike and running after the family. He's likely to have a lower risk of diabetes complications, like heart disease. It's life-changing. Remission isn't possible for everyone, but losing extra weight has lots of benefits. Better sleep, you can move more easily, and you can feel better emotionally and physically. It can also help to reduce your risk of diabetes complications, and you might need fewer diabetes medications. The weight management program tested by our scientists is amongst the strongest evidence we have for remission so far. But there are different ways to lose extra weight. Find something that works for you. There's still a lot we don't know about remission. We want to help people keep their weight healthy and stay in remission. We also want a treatment that works for people of different ethnicities or who are a healthy weight already. That's why our scientists are working hard to build our knowledge, so that together we can make remission a reality for as many people as possible.
So we've been beating up on the topic and getting questioning a whole lot of things. Again, I think, as I said before, you get a lot of questions in terms of just how are they defining diabetes? How would you define pre-diabetes? How do you define insulin resistance? How do you define, quote, remission? Having said all of that, The question still is, I think, is this significant evidence for a low-carb diet? And there's no question in my mind it is. It's very significant evidence that low-carb diet is very helpful. And I didn't need it. I mean, I work with it all day, every day. James, comments?
Absolutely agree. I've done some math for you as well. One quick comment just to get you frustrated is we're still having a delay feed for the people who are watching if they're seeing the same delay feed in the video versus the voice. We're either having a delay feed or you are the world's greatest ventriloquist because at times that you're talking, it'll go silent. So we ask our audience, bear with us. It's a streaming issue that we've struggled with. So
can I make a comment about that?
Yes.
We Gilbert and I noticed this, and I can see it right now. According to now, my video looks like it's about a minute behind my voice. We turned my computer off, looked like it had, and turned it back on, looked like it had cured it again. Last week we were having the same problem, and a little bit the week before. Right. It turned out last week that one of my patients that afternoon actually manages home call centers for a large hospital system. He said, yeah, I saw it, and yes, I do this for a living. And you may think it's your RAM. You can go back and try to clean that out like we had done. And we see this all the time. I don't think it's your RAM. I think it's local bandwidth issues. Right. And I just don't think you're going to be able to fix that. I don't think you're going to be able to problem solve that. So thank you for bringing it up.
I just, for the audience, and I know it frustrates you a little bit. We're doing the best we can. A couple of things on that diet to the point that you mentioned. So I think if my conversion ratio is right, with carbs, it's about a 4-to-1 ratio. So four calories for every 1 gram of carbs. Now, I know certain foods can maybe shift that a little bit, but I think that's a good rule. And fat is about a 9-to-1 ratio. So if you have a 1,600 calorie diet, then about 400 of those calories, according to that recommendation of 25% being carbs, that's going to be 25% be 100 grams of carbs. And I think you and I both agree, more importantly, you would say that's probably not a low carb diet. 100 grams of carbs is probably not a low carb diet. When you look at a 9-to-1 ratio, you could do 50% fat. And we'll talk about the kinds of fat that would be in my own personal experience in changing. But it's about a 9-to-1 ratio. So that's the math. And we can talk about specific foods in that. Broccoli, for instance, that the one doctor brought up, broccoli is about 9 to 10 grams of carbohydrates. But you might address what are called net carbs. You're talking about a definition, but it's sure carbs. Not all carbs are created equal either. Not all fats are created equal. So as a rule, we're saying higher fat, lower carbs, which got me excited. I went out and ate Kentucky Fried Chicken for a week. Didn't seem to work out so well for me. But that was tongue in cheek. But talk about net carbs, net fats, different kinds of fats, different kind of carbs, and maybe that'll help clarify for some of our listeners. And we'll talk about some of those foods if you want that I use and what their fat, what their calorie content is.
Well, to your point about fried chicken, I'll just tell you, as I told you last week, I've gotten back to my roots, and I have discovered a low carb version of fried chicken. I use pork panko.
And
I've loved it. I'm making large masses of pork panko fried chicken now, 0 carbs, because you got the pork crackling crumbs, the avocado oil, and the chicken.
Right.
So actually, I'm glad you did the math. I don't think I did the math that well earlier. I don't really think 100 grams of carbs per day is that bad. But again, I'm assuming we're talking about total carbs and not just net carbs.
Right.
What I would suggest, Gilbert, is maybe you could find pictures or stills of me and James, and when we're lagging like this, just put a still picture up so it's not quite as distracting.
Well, I'm not lagging, but if you're going to put a picture up, Gilbert, find Tom Selleck or Brad Pitt or something like that. Let's not put pictures. If they're going to look at us and it's live, I get it. If you're going to put pictures up, make us slightly better looking. That's my only suggestion for it.
I'm not sure I could tell the difference between you and Tom Selleck.
I didn't want to be ugly to you, Ford. So if you're going to make us all uncomfortable, yes, just put one over Ford's picture. That would work.
Anyhow, we've gone down a bunny hole that I'm not sure is that productive for
Not
folks. So I was a little bit surprised when you did that math. I do actually tell people that one good way of dealing with this is not overdoing it, not saying I'm going to restrict myself to 25 to 50 carbs total, because that's too hard. Now, to get back to your point, well, total carbs versus net carbs. So the FDA, in their infinite wisdom, has, and I'm being sarcastic in case, so in their infinite wisdom has said, look, we have to present, if you look at the organic chemistry, fiber, plant fiber is a carbohydrate. It doesn't matter that it doesn't impact your blood sugar at all. In fact, if anything, it tends to help control it by slowing the dumping of sugars from your GI system, from your stomach into your bloodstream. So when you look at a food label, you'll often see things like cauliflower and broccoli listed as a carb. Now that we're getting more health conscious, more glycemia conscious, you'll start to see net carbs. You'll see carbs, you'll see sugars, you'll see total carbs, and sometimes even net carbs. So what they're doing is they're taking that fiber out of the total carbs. And that's really much more realistic. Any comments about that, James?
No, other than, so if you do the math, you and I often talk about stealth carbs, and that's usually what catches people. For instance, if you need to limit to 100 net carbs and maybe lower, a regular Coke from McDonald's is 65 grams of that. So you're going to get most of your carbs just in one Coke a day. A Starbucks with a Frappuccino Mocha Wappuino is going to throw you out of your carbs. So it's those one or two little things. An apple is 21 grams of carbs. You got to net out maybe the fiber a little bit, but it certainly affects your blood sugar. Grapes certainly do. So that's the math. It's 4-to-1, and then you got to determine whether it's fiber or not in it. I think that is how we get our definitions aligned correctly.
Very good. I see your Aunt Martha's on.
Yes.
Daryl, is that her husband?
Daryl is my uncle.
Started using the Freestyle Libre. We've had a couple of other people comment about the Freestyle Libre.
We actually have a program for it. You might mention that. We have a program where they can reach out to us for a subscription to the Libre from PrevMed. So you might want to address that, because people ask that question. Where can we get the prescription, for a Freestyle? So do you want to comment on that quickly?
Sure. The big question most people ask is, how much does it cost? I don't know. You may know. But here's my view on it, that, again, I used to think I wasn't that political, but I'm hearing myself being sarcastic about more and more government agencies. I was always anti-big government. But anyway, the FDA, in its continued infinite wisdom, has decided that a Freestyle Libre needs a prescription. Why they decided that, I have no clue. I think what they may, they're always, how bureaucrats tend to look for potential danger. And I think the potential danger that some bureaucrat on the FDA committee may have said was, well, look, people are going to try to adjust their insulin based on this, and that's dangerous. Well, it's dangerous to drive a car at 90 miles an hour with your eyes closed too. I mean, people do a lot of dangerous things, but what they've done is they've made continuous glucose monitoring unavailable for the masses, unless you can convince a doctor to write you a script, and that's just flat wrong. And so I've got licenses in over 40 states. I'm totally comfortable writing Freestyle Libre for folks. If you have an interest in getting a script for Freestyle Libre, give us a call, 859-721-1414. That's 859-721-1414. And the bottom line is, knowing what your blood sugar value is critical on a day-to-day basis. How does it respond when you go for a walk? How does it respond when you eat lentils? How does it respond when you eat, you get up and you have that, quote, healthy breakfast of orange juice and oatmeal versus that really bad breakfast of bacon and eggs? Well, I can tell you, you'll be surprised if you think that the first is healthy and the latter is unhealthy. Major surprises people get when they actually start using it. In fact, to go back to the car analogy, the FDA decision to make this a prescription is analogous to taking away a dashboard, a speedometer on car for health. You know, it's like having a speedometer there, and you really need it. You need to understand how your blood sugar responds to what you eat and what you do.
And by the way, to your point, Ford, that I agree with you, because sometimes I say common sense. You don't have to have a script. You can get your hands on all types of measuring meters, you know, the finger stick kind. So if someone wanted to play that game, they could do that. They just have to stick their fingers more often, you know, create more pain. Right. But if someone wanted to say, I'm gonna manage this myself and not work with my healthcare provider, well, that option's already available. That abuse is already there. You're not changing the ability of someone to abuse it. You're simply, you know, making their life more incompetent.
I'd be careful. There's a couple of things if you're going to do that. One is, you still don't figure out what's going on. You should get a decrease in your blood sugar about 3-4 in the morning, right before that cortisol dump happens. And you're not going to find that just by doing repeated finger sticks. The other thing is, be careful which finger stick device you get. The cheapest ones are often so wrong as to be worse than worthless. None of them are perfect, but I think Contour, for example, is sold by either CVS or Walgreens. I think it's CVS, and Contour is really, really bad. On the other hand, there are some that are really good. The Abbott Freestyle. I'm not talking about the Libre, just the Abbott Freestyle devices. There's a Neo, there's a couple of others. And no, I do not have any financial link to Abbott or the makers of any of these things. I'm not the ultimate expert in this area either. That would be Richard Bernstein. He's a physician living about 10 miles from where I used to live in New York, the father of diabetes self-care.
Right. A lot of the comments and questions we're going to get into relate to this. We're getting a lot of great comments. And one of them is, we'll jump ahead around oatmeal. And since we're talking about the meters, you know, the debate around whether oatmeal should be netted out for the fiber. Well, the Libre, a continuous glucose monitor, helps you determine that. So if you get a continuous glucose monitor and you really want to find that answer out for yourself, you can eat oatmeal. Now, I can tell you in my own personal history, years ago, when I worked with a personal exercise assistant, I had a trainer, and she recommended that I eat oatmeal in the morning. She said, eat oatmeal in the morning. And I needed to lose weight. I wanted to exercise. Well, I was exercising like a madman because I was paying somebody to help me. And I was eating that oatmeal, and it really wasn't losing a lot of weight. You'd think I'd know better than this. This is 10, 12, 15 years ago. She said, well, what kind of oatmeal are you eating? Well, sometimes I have the brown maple sugar oatmeal. Sometimes I have the strawberry and cream oatmeal. I'm just pouring that sugar down me, you know, with all the sweeteners that were in the paper oatmeal. So, of course, you know, I'm just spiking my blood sugar in the morning and just burning when I'd exercise, I just burning the carbs out of my bloodstream, not really affecting any weight loss. So using the Freestyle Libre and then eating the right kind of oatmeal, you know, not pouring sugar or sweets or honey or anything that increases that glycemic index, you'll be able to see very quickly. I've done it. I still do it. You'll be able to see very quickly the impact that food has 1 hour, 2 hours, 3 hours after eating, and you will find a lot of surprises.
Yes, you will. Some of the worst oatmeal to eat is the instant oatmeal, the rolled oatmeals, the things that have been powdered, because it just grinds up those carbohydrates where they can hit your bloodstream all at once.
Mm-hmm.
I'm looking at my picture. It looks like I'm looking at my foot or something.
Well, yeah.
There you go. Picked the most opportune time to freeze, didn't it?
You know, Gilbert, if in the future, if you can find a picture of Doogie Howser, and just whenever he freezes, just put that picture up there, and everyone will think it's all the same. So that's how we'll solve that question.
What a headache! You know, it's we've talked many times. It's like spouses. Can't live with them. Can't live without them. Technology is just can't live without it anymore. But it can be a headache too.
Or on to the questions. We ran a lot of bunny holes. We burned up the hour already today, but we covered a lot of the questions as well. Some of this conversation was both of us checking this and seeing some of these issues. So you can scroll through them and maybe hit some of these questions about the diet if you want, since we've used up a lot of our time already.
I did see one question from my BJJ. I think that was well, again, my system has gone wonky again. I think it was my BJJ that asked the question about atorvastatin. I think he said he saw a study where atorvastatin was banging on the beta cells. It may actually do that. It is, it's well known that that all of the statins except one push you down that insulin resistance highway, that diabetes highway. So why would you give any statins at all? Because I give statins, for example. I give them for another reason, for cardiovascular inflammation. The other thing is I don't use atorvastatin at all. Atorvastatin doesn't do as much positive work for inflammation as some of the others. There's a couple of other comments about statins. When I use them, I almost always use a very low dose statin, because low doses will impact that cardiovascular inflammation, that immune system storm against plaque, but they don't have nearly as much impact on the beta cells or the insulin receptors. There is one statin we're using more and more now that it's becoming affordable, and that is pitavastatin, or Livalo. That among the statins, it's the only one that does not increase insulin resistance. There was another comment from one of the, again, I can't find it now. It was a question about the COVID vaccines. And here's just a real quick question. Doc, what's your perspective on the vaccines? I would take any of the vaccines I could get, and I would almost even take the Chinese Sinovac vaccine. And I expect to get a lot of haters on that comment. But here's the thing. Every vaccine, no matter which one you're talking about, even the absolute best one, can cause problems. One of the reasons I wanted to go ahead and respond to that question about vaccines is that we're starting to get a little bit more clarity on those problems. They tend to be associated, when significant problems happen, they tend to be more of an anaphylactic type of reaction. And it's people that have this rare anaphylaxis to lipid layers. You know, these are put out in a lipid pocket. And there's a simple old product that's got lipid in it, or fat in it. James, you're fat or wax? My wife was telling me about it yesterday. We have a family member who's got nut allergies and was talking with an allergist immunologist, and she said, no, I don't have any concerns with you. She said, if you have an allergy to blank, and it was an old household product. You don't happen to remember what it was, do you?
No, I have not seen that.
I'll have to look that up. I meant to do that for this channel. But again, the major underlying response is, number one, there's no question that if you're going to get exposed to that spike protein sooner or later. If it's not within the next for most of us, it's going to be within the next 6 months. For very few of us, it may be more than 6 months before we get exposed to that spike protein. So if you're going to get exposed to the spike protein, you got to ask yourself the question, which poison do I want to take? Do I want that spike protein to be associated with a whole virus, or do I want it to be something that's been cleaved off and got all the problems with vaccine production and vaccines, et cetera, and all the politics, et cetera? Or do I want to go head to head against the whole virus? I think once you start looking at it that way, you begin to get a slightly different perspective regarding the politics and all the other junk that can go, and the big pharma money, all the other junk that can go with a vaccine. James, I know you've got a slightly different perspective on vaccines. I've sarcastically called you an anti-vaxxer. You corrected me, and you may want to restate your position and maybe give your reaction to the comment that I just made.
No, we agree. My own wife brought that up just last night. Because someone called and asked me which one I was vaccinated. I'm not. I'm in level 2. I'm over 50 but under 60, and I don't have any underlying health conditions other than mental health incapacities. So I'm still at 2, and our county is still in 1A. They haven't completed all the vaccinations, but when the time comes, I'd be vaccinated. I'm more comfortable to have waited into seeing. I was doing a lot of preventive things around not getting the virus if possible. You and I both, we can say the reason I was out last week is I was sick, and we thought for a while I probably did have the virus. I tested negative twice, but I had come to find out people still get colds, flus, and sinuses and allergies and sicknesses. But when the time comes, I'll get the virus. I think I'm more concerned about children under 16 getting the virus, and I was more concerned, and I am still concerned with why they pass the virus out to healthy people who are politicians like Congress people, giving them the shots when there were nursing homes that hadn't been tested yet. So I think I'm just more measured in watching than I am anti this particular vaccine. And I am one of those, I think, studied concerned about children under 2 getting a lot of vaccinations, piling it on prior to age 2. I'm more of those, the Japanese approach, to stretch it out over the first 4 years of their life. And
don't bunch them all up.
Don't bunch them all up. Don't.
Yeah.
Because it's not the vaccines. I'm not one of those that think that aerosol or the other things are. I just think there's something, and it goes back to a lot of research we did at My Genetics and a lot of the studies we read, that it's something to do with the same mechanism we studied a couple of weeks ago on this channel about what may be occurring in the immune response, that some people seem to have a system that once that switch is flipped, it's hard to turn that off. And so you get some respond adversely, more severely. And if you over challenge the system, I think that may be where some of these anecdotal stories are coming from, because I believe that there are some stories. We know there are some stories because there is a fund that pays people who are harmed, from bad vaccines. Guillain-Barré is a real result as to what happens sometimes. It's rare, but I'm not certain that it's the shot as much as my response to that shot, just like the anaphylactic response is to these vaccines. It doesn't mean the vaccine is bad, but I may not be, my response may be the issue. So I'll certainly be vaccinated when the time comes. I'm not going to jump in line in front of someone else, but when my time comes, if I haven't had the virus yet, I'll be vaccinated.
You bring up a good point, and I want to emphasize it. Guillain-Barré. It's, you know, that sounds kind of dry and clinical. If you look it up, you can get a really gut level picture of this. Look up iron lung and vaccine. When I was at Hopkins and studying public health as a student, that's one of the things we talked about is that fiasco, that problem. And there's no question that a lot of people have been damaged permanently, and a life-threatening damage from vaccines. There's absolutely no question about that. And
but millions and millions and millions of lives have been saved, and so that's the balance that we have to go through. There is no denying that polio, the world is changed because of polio vaccines. The world is different because of the measles vaccine. I mean, there are just absolutely tremendous good that's done. You know, we banter and joke. I take the adversarial approach just for simpler conversation most of the time, but there's great and good that's done. We don't deny that. It's just you got to be aware. And just like with your own prevention, everyone's responsible for their own health and becoming as informed as they can to the choices they make with their own body.
You brought up, you took the words right out of my mouth. That's exactly right. It's when these physicians and public health people study the iron lung problems that happened with the vaccine, 50 years ago, 40 years ago. It's similar to pilots looking at, and they did, looking at airplane crashes. When you look at the aftermath of an airplane crash and the body's laying on the ground, it's ugly. But people still get back in the airplane, and we know why. And it's the same analogy. We have risks with every decision that we make. I want to do a quick shout out to Type 1 Talks. He's made several comments, very helpful comments. Let me just read one. I use Freestyle Libre as well. It's been a game changer for me. Showed me so many things about how my blood sugar reacts real time to all kinds of food that I had no idea about. He goes on to say he's not just a prediabetes patient. He's not a type 2 diabetes patient. He's had type 1 diabetes for 30 years plus. So it's really helpful, Type 1 Talks, when somebody like you comes on, you make a few comments, you share with others, because it's one thing for people, like James and me, who have maybe the temerity or maybe the lack of good sense to get up and talk about things as a self-appointed expert in an area, as a guide. But it's very different for people to hear from someone else who's on that same journey. At the end of the day, when you look at what we're doing, it's you guys, it's your journey, it's your life. We are trying to help. The goal for this show is to help you in your journey. Your comments help us immensely in terms of doing that, and we appreciate your views. We appreciate more than anything else your feedback.
Absolutely. And Dr. Brewer, is temerity over the counter or is it a prescription?
I was hoping you weren't going to catch me on that. I don't even know how you define that. I heard somebody else use that once, and I thought it sounded good, so that's why I used it.
That Hopkins education is coming out. And for our audience, we also have some partners that went to Harvard and Yale and some of those others, and I tell them all. I said, look, just because you couldn't get into David Lipscomb, I understand you had to go to some other school. So.
Thank you so much for your attention. Anything else, James?
No, I think this is great, but a great series. Look at on this diet. We're going to bring some more content up and talk about walnuts and eggs, boiled eggs, and the impact that they have. But follow up on the Freestyle Libre. I think we had my Aunt Martha talking about. She started this week, and her husband started, and it's a great experience. I think if you haven't done that, you should. Build your life around that, and you will find, like me, when you got me on this a few years ago, I lost 35 pounds, and I've kept most of that weight off, and it's a lifestyle between that and fasting. So hopefully people get that point out of it, and make a difference in reversing this disease.
James, as I've said to you a couple times over the past week, you haven't told your the story of your journey recently.
I haven't, but we'll do that on another show. Maybe when we do, my experience with the CGM. But for a quick note, I've known Ford for years. We worked together, and I had ballooned up, gained some weight, and Ford got me on exactly what I jumped in, did what he told me to do. I lost about 35 pounds. It was a combination of a low carb and fasting. Fasting, I think, is a critical point, and I've stuck with it. Christmas time's a little more difficult. People keep bringing these pecan pies around. My Aunt Martha keeps making food for me. But other than a few carb holidays, we call it, we stick with fasting, and we stick with a low carb diet, and the weight generally stays off, and my blood pressure lowered significantly. And that's before Respirate and other tools that we have available.
Thank you for sharing that, and I look forward to getting a little bit more into detail on it. I keep trying to sign off, but there's another great comment. It's a question here. It's from Ann Sampson in Granbury, Texas. She's saying in Granbury, Livalo is $300 a month, and insurance doesn't cover it. Is there a way to get it cheaper? The answer is yes. She considers $300 a month expensive. I do too. So it's still another couple of years before Livalo gets off of its breaks its patent, and then it'll be 2 to 3 years after breaking patent that it really drops the price. We were giving a presentation once at one of the events. Actually, David Mintz, the dietitian I was telling you about, shared with the group, and he shared on this channel that he's been a patient as well. He went that route of getting Livalo from a Canadian pharmacy. So hands just kept shooting up. David handed out the information on Canada Pharmacy Online. I tried it myself, and so I've got a ton of people who are getting it. It's about $1 a pill. So that's about what? $30 a month. So yeah, and there's ways to do it better and less expensive. Thank you again for your interest. And I'll sign off unless you have anything else, James.
Thank you, Dr. Brewer. Great job.
Bye-bye.